Hi everyone, I'm Dr. Ushma Bhojani, Women's Health Physiotherapist, Clinical Instructor for Invasive Pelvic Floor Rehabilitation for WOW IIPRE. This case report that I'm going to share today aims to show the effectiveness of physiotherapy management in a 40-year-old patient who is diagnosed with urine retention. Urinary retention is inability to voluntarily void urine or inability to completely void urine voluntarily. Typically, it is diagnosed when there is a high post-void residual volume on ultrasonography. Today, I am going to share a very special case of a 40-year-old female who was referred to us by a urogynecologist with a chief complaint of inability to completely void urine. She complained that she had to strain to achieve complete voiding. Even after straining, she used to feel that some urine is still left. For the same reasons, the urogynecologist did uroflowmetry and urodynamics that suggested bladder outlet obstruction. In order to treat the same, urethral dilatation and cystoscopy was done. Post-procedure, she was better for few weeks. After few weeks, she had similar symptoms. On ultrasonography, her post-void residual volume was around 181 ml. If she had to control passing urine while washroom is not available, it used to give her pelvic and perineal pain. And voiding completely used to become even more difficult post holding back for long. She also complained of lower abdominal pain during coital activity, and post activity the pain used to settle in around 10 to 15 minutes. She is a homemaker and a mother to a 10-year-old who was delivered via C-section. Her periods were regular and she was on antihypertensives for last 2 years. Her comprehensive assessment included assessment of posture, external pelvic muscles and pelvic floor muscles. For internal pelvic floor assessment, her written consent was taken. During internal assessment, there was no use of accessory muscles. Response to cough was inwards. On palpation, the outer ring was tighter than the inner ring and there were trigger points at 2, 3, 5 and 7 o'clock of the internal and external ring. On Hates MMT relaxation scale, she was on -2. And on the SURF scale, her endurance was 3 seconds for 5 repetition. Her fast twitch muscle score was around 7 repetition in 10 seconds. Her female sexual dysfunction score was 20 on 50. Her bladder diary showed urine frequency of around 12 to 15 times a day with a minimum volume of 40 ml and a maximum volume of 120 ml of urine. Her urine stream was broken and used to go sideways. In Hates RR scale, she was on stage 3, which is intentional and partially able. She could only partially do the relaxation part of it. Post-treatment on discharge, during palpation, there were no trigger points. Pelvic floor relaxation on Hates MMT scale was -3. She was able to do pelvic floor contraction for around 10 seconds for 10 repetition. Her fast twitch muscle score was 10 contractions in 10 seconds. On Hates female sexual dysfunction scale, she was on 42 out of 50. Her bladder diary showed urine frequency of 8 to 10 times a day with minimum of 120 ml to maximum of 390 ml of urine. On Hates RR scale, she was on stage 6, where she had developed subconscious reflexive behavior to relax the pelvic floor muscle whenever required. In her treatment protocol, a detailed explanation of bladder and voiding mechanism played an important role for her to understand the relaxation mechanism and to prevent straining while voiding. Mirror biofeedback was used in order to activate and relax pelvic floor muscles isolatedly. Soft tissue mobilization techniques were used intravaginally for the trigger points, which gave pain and discomfort. Methods used were sweet spot release, Thiel's techniques, and Weiss-Anderson's techniques. WOW PF360 modality was also used to relax tight and spasmodic muscles. Mainly shaft activation, Bartholin's activation, and relaxation program with Glaser's protocol was used. Sessions were done on alternate days and was asked to make bladder diaries for the days when she used to not come for the sessions. Treatment outcome post 10 sessions was that patient's urine frequency reduced to 8 to 10 times a day and was able to pass approximately 200 to 390 ml of urine in most of her voiding visits. She did not have to strain and her coital activity was also no more painful. Urine retention can have multiple medical causes. After eliminating all the reasons if urine retention and hesitancy persist, then evaluating and treating pelvic floor muscles can be considered as a very helpful aid.